nutrition, being the backbone of pediatrics, needs a much more emphasis. I am immensely pleased to welcome Dr. Somasekar Sir, former Dean of Kanyakumari Medical College, former Professor of ICH, former State IAP President, Vice President in National IYCF Chapter, currently Professor of Balaji Medical College, a strong advocate of breastfeeding and infant and young child feeding practices in Tamil Nadu, and Dr. Shrija Sugunan Ma'am, Associate Professor of Pediatrics, taking care of PICU from the famous Sage Hospital, Trivandrum, for the next case presentation by Dr. Aarti from Balaji Medical College, Chennai.
Good afternoon to one and all present here. I will be talking about severe acute malnutrition today. Baby Charan, 10-month-old male child, second born to a non-consanguineous marriage, residing at Tirupati, admitted on 20th February 2020, informant being the father, whose reliability is fair, was brought with the complaints of vomiting since 1 month, 10 to 15 episodes per day, non-projectile, containing milk, non-bilious, non-blood stained, abdominal distension since 5 days, generalized in onset, gradually progressing, which has now subsided after treatment. History of poor weight gain. The child had been gaining weight adequately till the 8 months of age as per the mother before the onset of the above mentioned symptoms, after which he started to have excessive weight loss. There was no history of diarrhea or passing bulky stools, frothy or pale stools, no history of edema involving any other region, no history of recurrent respiratory tract infections or ear discharge, no history of decreased urine output or crying during micturition, no history of yellowish discoloration of eyes and skin, no history of bleeding, gums, swelling of joints, no history of any oral ulcers, whitish plaque over the oral mucosa, and no history of contact. Yes, sir.
Stop. Okay.
You are going see, very fast. Let's just discuss.
So, before you come to the course of the hospital, you said that there's a child who's presented to you with 1 month history of vomiting. What are the differential diagnoses that comes to you at this point of time?
Ma'am, the most likely it could be that she's improperly feeding the child. So we should ask about her feeding history. Often mothers, they feed the child and then they just make the child lie down, posturing after feeding.
But the child did not have a problem with the feeding for the last 8 months. So the same mother is feeding now also. What happened suddenly in this month? Would you like to have anything more from the history? An onset of recurrent vomiting at 8 months of age. What history would you like to know?
Something which is bothering here.
And it's not an acute symptom. It is there for 1 month. It may not be related to this child, but still what would you like to know? Won't you like to know if a new food was introduced?
Yes, ma'am.
Or type of food? Okay, why do you want the type of food? What could precipitate a vomiting, a new introduction? What disease are you thinking about? Cow's milk protein allergy. Okay, good. Anything else? Very good. Fructose intolerance. Inborn error of metabolism, fructose intolerance you can think of. Anything else? Celiac disease, gluten sensitive enteropathy. So that should come to your mind. So it becomes important for you to know that how the vomiting started, the exact onset, whether a new food was introduced, whether it was related to that food, whether that food is still being continued. Then you said about abdominal distension. So that is happening only in the last 5 days. I would like to know what happened to the bowel and the bladder habits. Isn't it?
Yes, ma'am. Ma'am, as I mentioned, ma'am, the bowel and bladder was unaffected. She was saying that the child was passing small quantities of normal consistency of stools. There was absolutely no diarrhea, and the child was passing urine adequately, ma'am.
Okay. So, after that is a contradictory statement because you are telling me that one of the mother's main complaints is for the last
vomiting.
1 month the child is
vomiting.
And that too 10 to 15 times, 10 to 15 episodes per day. And that is definitely more than the number of times you are going to feed the child. And also you are telling me that she's passing adequate amount of urine. But at the same time, one of the main complaints is poor weight gain. So it becomes important for you to know the comparison. Is he passing the same amount of urine as he was passing before the onset of the illness?
Definitely not, ma'am. She's saying that before like the onset of the symptoms, it was better. Now he started passing lesser, but not so much for her to have an alarming effect that okay, my child is passing less amount of urine.
Okay, but I would like to know what happened during the 1 month. You have jumped straight away to this hospital admission. But she must have done something for the last
Yes,
1 month.
yes,
So
ma'am.
that
That was in my past history, ma'am.
no,
Okay.
that's a present complaint.
Ma'am, she was taken to a nearby hospital in Tirupati, ma'am, where the child was apparently underwent a lot of tests, USG abdomen and all that was done, ma'am. They investigated extensively, and the child was referred here in view of some gastric surgery that had to be done, ma'am.
But I also would like to know what was the feeding habit during this 1 month.
Ma'am, she claims that she's only been given milk to the child. She was breastfeeding the child initially, and complementary feeding was started. But as the child has developed vomiting now, she only was giving milk, and that also the child was unable to tolerate. So in this 1 month, the child has been unable to tolerate even oral foods.
Okay, so why did you ask for those diarrhea, passing bulky, frothy
Ma'am,
stools?
to just rule out any malabsorption, any lactose intolerance, because it's just at 8 months. Before this, the child was doing okay.
What would be the history for a lactose intolerance?
Ma'am, it's actually uncommon at this age a little, but just for the sake of completion, ma'am, frothy, bulky, very smelly
Primary
stools.
lactose intolerance in our ethnic group is very rare, but of course it can be followed by a rotaviral diarrhea by scrupulous use of antibiotic and changing doctors and so on and so forth. So therefore, there will be a soapy, soundy with a sore bottom. The 3 S you should to incorporate and look into, if at all, if you think of a secondary lactose intolerance. That is also to be there.
Coming to the past history, as I mentioned, that
I agree, because this is the ecology of this particular case with undernutrition especially is different following a subset. So there is a little bit, I think, probing into, but routinely if you could probably refresh into the ecology of others apart from the organic cause, I think one should, adhere to what all the histories which are set, framed, that you should look into. That is what the madam is trying to explore from you.
The past history, there was no history of any infections, any exanthematous fever, tuberculosis, jaundice, any history of prolonged loose stools. The child has just had a previous hospital admission, after which they were referred here for surgery. Family history, there's no history of TB, HIV or any chronic communicable disease, and there's no complaint in the other sibling who's currently 5 years of age.
In the course in hospital, would you all like to know anything more? So this is a child who has come to you apparently with a normal nutrition status and has something happened over the 1 month symptom, then has undergone a surgery, and now the child is here in front of you. You can have a look. Won't I like to know something more? Wouldn't you like to know something more? What would you like to know? The course in hospital. Yeah, what happened post surgery? How many days the child was on IV fluids? What is your comment on IV fluids and nutrition? How much percentage of your daily requirement of calories will be provided by your fluid? 70 to 75% of your calories will be provided by your maintenance fluid of 5% dextrose. 17%, very good, 17%. So 17%, so a child on fluid will lose weight or gain weight? Will definitely lose weight. 1% of weight would be lost every day if the child is on fluid. So I would like to know whether the post-operative period was catastrophic. How many days they could give an IV fluid? Did they start an enteral feed? If they started an enteral feed, what was the enteral feed that was started? What was the frequency at which that was started? Whether the child was offered a total parenteral nutrition? All that is important for this child. Hospital history. When was the bowel movements established? Did he have a vomiting after that? Were there any childs of malabsorption post-surgery? All that are important.
Ma'am, so the child was not, as per the parents, no enteral feeding was given. The child was on IV fluids for the first 2 days, after which slowly they introduced milk. That also she's not breastfeeding after the surgery. She's only giving cow's milk, initially diluted, and now she's giving whole cow's milk.
Why was the breastfeeding stopped at that point?
Ma'am, she's claiming that in the last 1 month she has not fed the child, so she's no longer getting secretions, and we have to
But you told me last 1 month she was only breastfeeding.
No, ma'am. Before the surgery, like 8 months before, she has been breastfeeding. Since the problem has started in the last 1 month, she's not fed the child because of recurrent hospital stay, surgery, and now she's unable to get breast milk. Though in the night, I think PGs have counseled her really well here, so she's starting to relactate the child.
No,
She's giving in the night.
We strictly enforce BFHI. So I don't think the child could have been, ever advised about not to breastfeed. What went wrong? What is the missing link here? You should apprise into. I think Srinivasan had really spoke earlier about the nutrition critical situation. I think it's a special situation where you'll have to look into, isn't it? I agree. This is a thing which knowledge is lacking, especially with the surgeons. When it comes to burns also, they often call us. What is the fluids, how much to give, when will you start introducing, all those things are to be addressed to here, isn't it? So the child was devoid of the post-surgical nutrients. That is what is lacking here. Okay.
Ma'am, after the surgery, there was the mother claims that the child had 1 to 2 episodes of vomiting. That was also on post-op day 1. Followed by which the child has been tolerating feeds well, and stools were established after 24 hours, ma'am, like almost POD2. Again, not passing any watery stools, normal consistency that was there before the surgery only, ma'am.
Okay, yes. You can ask.
Here, suppose this is child been on only IV fluids, and the child is now presenting with on the day 1 of surgery. When you think of vomiting, so something which the child is not able to tolerate, isn't it? So is the child being starving and exclusively on IV fluids alone? In such situation, what will you do? Next weeks, how best you can advocate?
So you can start with like milk and some diluted, like initially
How
fluids,
will you administer?
or a small quantity of fluids, or
Any
like
other method of administration?
Sir, in
See,
her
there
you
are
can ask.
situations you will not give, you should not give, you are not supposed to give. There are situations, isn't it?
Yes, sir.
Here is a situation where the child should be given.
Sir, like you can advise her probably to re-establish.
Sir is asking if there is a GI contraindication for enteral feed.
Enteral feed, it's not there.
No, sir.
Then
So what is the alternative feed you give? How best you give? How much you give? What is your ideology? Do you have any concept of PPN, TPN?
Sir, but this child did not receive any TPN, sir.
That's what. So when there is the existence of the pediatric nutrition department, there was lack of convergence. So this is what is important.
The question was not whether the child receives. I was asking what could be offered. What are the indications to start?
Okay.
So
Right.
majority things.
The interministerial and inter-transsectorial convergence with probably is lacking here. Okay, I will be concentrating and telling you about the audience about at the end of the presentation about it. Okay. Which the government of India is very keen, right?
And regarding past history, if could it be again from the point of view of vomiting, you should have asked whether it was a post-tussy vomiting also. Okay. Not pertaining to this child. If any other child comes to you with a malnutrition, in the past history, what else would you like to know? You said about exanthematous fever, tuberculosis. Last presentation also, excellent discussion last presentation. There also there were 2 diseases that was mentioned specifically. But the reason why it was mentioned there and why we want to mention are different. What is those diseases you would like to know in the past history? Yes, very good. Measles and pertussis. Because these are 2 diseases. Why malnutrition, these 2 diseases are important? Because these are the 2 vaccine preventable diseases that cause immunosuppression. So that becomes important. So when you say past history, it is important for us to know whether there was any vaccine preventable disease, especially measles and whooping cough and diarrhea you have rightfully mentioned. And you have rightfully mentioned in the family history, you are looking for chronic infections, you are looking for immunodeficiency there. That is good. And you have also mentioned that the child is currently 5 years old. Why is that important?
Ma'am, the inter-pregnancy period, like
you want to know whether the inter-pregnancy spacing is good or not. Okay.
The child is presenting at 9 months. I am sure child must have not received the MR
9 months vaccine. I'm coming to that, sir. He's not received the MR vaccine, sir. Birth history, the antenatal period. The age of conception was 24 years. Mother was registered and immunized at their native place. She claims to have received iron, folic acid and calcium tablets with adequate immunization. History of adequate weight gain was there during pregnancy. No history of receiving any blood transfusion during pregnancy, and no history of any other complications.
Okay. So now we would like to know that what do you understand by an adequate weight gain? What is adequate weight gain? How much do you want? If the mother knew the weight, how much do you want the mother to gain weight?
Ma'am, 10 to 12 kgs.
It depends on the, is it same for every mother, whether you're obese or whether you're malnourished? The weight gain is different for different mothers depending upon the nutritional status. So for a normal mother, how much do you want to gain? Minimum 11 kgs, minimum. And if the mother is malnourished, minimum weight?
15 kgs.
13 kgs. If the mother is obese, 5, minimum 5. Okay, overweight is 7, obese is 5. I'm talking only about the minimum, I'm not telling about the maximum. Then we said about iron and folic acid. What is the importance of iron in pregnancy? What is anemia related to in pregnancy? If the mother is anemic?
If the mother is already malnourished, like if she is suffering from anemia, that will predispose the child to have anemia, and reduced iron stores will be there in the child. Also, the child may be a low birth weight or an IUGR baby if the mother has all these factors.
What is the approach called as? It's a life cycle approach to give Pink India. Anemia free Pink India. Okay. So like Kavalan application in your WhatsApp, I request all of you to download Anemia Book Bharat application at this juncture. Okay.
So we want iron to be supplemented. So how much iron for the mother?
Ma'am, you give, they've given 100 milligram tablets with 500 microgram of folic acid as per the National Iron Plus Initiative for 100 days, ma'am.
That is NIPI you are talking of?
Yes, NIPI, yes, sir.
Okay. Iron?
100 mg, sir, and folic acid 500 microgram for 100 days.
Once more read that, okay, that part. Okay. And if the mother is anemic, then what would you do?
Ma'am, you will give iron only and you will just monitor.
The dose of the iron depends on the gestation of the mother? No. Naturally, the iron depends upon whether you have anemia or not. So read it up. What would you do if a mother has a normal hemoglobin? What would you do if the mother has anemia? What is your target hemoglobin during pregnancy? 11. 11. Okay, so that also we need to know because that's an important thing when it comes to this. Then you told me about the mother being...
Iron deficiency is not synonym with iron deficiency anemia.
Yes,
okay?
That's very important. Very important. So you said about immunization. What immunization are you talking about in the mother?
Ma'am, usually when we talk about appropriate immunization, we are talking about TT. However, in this case, if the mother has received any rubella vaccine when she was earlier, ma'am, so she says she has received them. Not during her pregnancy, ma'am, earlier.
No, we are talking about mother was registered and immunized during her pregnancy. That's what you meant, right?
Yes, ma'am.
So what vaccinations are you going to advise this mother during pregnancy?
Ma'am, you're going to advise 2 doses of TT, ma'am, 4 weeks apart, and the second...
the last childbirth was more
than 5 years.
What is the, if this mother was coming to a private sector or the mother was affordable, what vaccine would you recommend?
Is that same
Tdap, ma'am. Tdap,
you would be recommending Tdap. At what age?
20.
What age?
20.
What gestational age?
20.
Third trimester, 27 to 34 weeks. That's what you wanted. The earlier the better. Why do you want to go for Tdap?
No.
You are trying to prevent the pertussis in the newborn. That is because 80% of pertussis mortality happens in infants. So that's the only way of preventing. Next pregnancy, you're going to opt for TT or you're going to continue with Tdap? Every pregnancy, Tdap. What does the government of India say? Is it TT now?
It's Tdap.
No,
it's Tdap, ma'am.
Not Tdap.
Tdap.
It is TD. So we should be telling TD. Now, if this mother...
Foxy recommends Tdap. Government of India, Ministry of Health recommends TD because we are a poor country as far as still we are concerned, but it is not so.
So TD should be the answer, not TT, because TT has been replaced, and you should also know regarding the TDAP. So if this mother was completely unimmunized, what would you do?
Ma'am, then when she was she's already delivered, then you make sure that the child receives his routine immunizations.
Anything for the baby?
Ma'am, at birth, you can, no, ma'am, you give the 6, 10, 14 weeks of tea.
Is that enough? Yeah, if the baby is born to an unbooked mother who has not received any vaccination, the baby needs to get TED glow. Okay, only then. Can proceed.
The intranatal
So pregnancy is not a contraindication for flu. Flu vaccine.
Flu vaccine also, pregnancy is not a contraindication.
The baby was born via normal vaginal delivery, full-term delivery. Birth weight was 3.5 kgs. Cried immediately at birth. No history of any NICU admissions. Passed meconium and urine on day 1 of life. The mother started breastfeeding at first hour of life. No pre-lactals were given. The child was exclusively breastfed till 6 months of age, post which complementary feeding was started, and there was no history of bottle feeding till 9 months of age. Currently, she is feeding the child in the hospital using cow's milk around 7 to 8 feeds per day, approximately 100 ml per feed, along with Protein X powder that she's giving, 6 teaspoons of it per day in a bottle, which she is not sterilizing adequately. She's just washing the bottle once in the morning with just water and probably air drying it. The baby is receiving 590 kilocals against an expected of 750 kilocals, and the protein that the baby is receiving is 33 against an expected of 15 grams.
Anything more you would like to know?
This is an important area where the child has fallen victim to this present problem. So you have to further probe into the complementary feeding history very well, to the probed into further, not only with 24 hours recall as well, whether the baby was started with a food diversity and all.
Sir, earlier she was saying that she's only complementary fed the child for 1 month, after which the child started having vomiting and she's gone back to giving milk to the child, and then the whole process of hospitalization, and she's lost breastfeeding in the bargain. So the child effectively has only received 1 month of complementary feeding.
So this is the real situation, and here is the present scenario. One should look into very carefully about the NFHS data. See, the NFHS data 3 says 52.6% only, but if you look at the NFHS 4 data, it is 42.7%. Okay, the complementary feeding. So with reference to complementary feeding, there is a decline. So we are able to give the therapeutic appropriate complementary feeding to the tune of only 9.6%. Here is an example. Here is an example in front of you. Okay, so where is the food diversity? Goes into who is lacking, who is at fault, why this target is not there.
Arati, I would like you to, this child, 7-month-old, is coming to you. Advice regarding the complementary feeding.
Ma'am, initially you can tell them as ethnicity diversing, ma'am, whatever food they give, whatever staple diet that they have. Here we generally advise like rice kanji or something to start off with. She said that she was giving...
The complementary feeding, with reference to complementary feeding, it is should be number 1 is the home based.
Yes.
With the affordability, number 2. And whether he has the accountability of what should be given. Isn't it? So, the feasibility, affordability, accountability and availability, that is more important. What is the knowledge? Whether the baby, mother who has a habit of hand hygiene, she is washing the utensil, washing her hands properly before and after, everything matters. Okay. So, did you go into all these details about in this mother, with this mother?
Sir, I just asked her what she was giving by complementary feeding.
See, this is the mother, very clever. Nevertheless, not bottle fed since the situation is.
Yes, sir.
So, we must first of all congratulate her for having exclusively breastfed. Isn't it? So, after that, what happens? We are at fault. We have not given the foolproof guidance, advice about what to give, how to give, when to give, what not to give. That is the situation where she went down. Even before the illness at 9 months. You see, post which complementary feeding was started. I am happy. No bottle feeding till 9 months. Very happy. But what complementary feeding? That is what madam is asking. What advice will you give?
Practical advice.
You were there in that scenario.
Sir, initially you can start off with, as I mentioned, ma'am, that whatever she's preparing at home, whatever she's comfortable to prepare at home,
I think
whatever.
the first sentence should be continue
breastfeeding.
Okay, then comes the second part of complementary feeding, which you rightly said you want the home available food to be started with. That's very good. The next I would like to know is the consistency and the quantity.
Ma'am, you should give whatever is locally available to her and whatever is feasible to her. Okay. And the quantity, ma'am, initially you start off with low quantity. If the child is tolerating, then you slowly increase. She had a doubt about, I think she had asked some doctor about starting non-veg to her diet, so they were advised that they should not give it till 1 year of age. However, we can tell her now that since she's in a better institute, that she can probably start egg yolk first at around 7 months and then followed by egg white at around 9 to 10 months. Also, she can give rice preparations mainly, ma'am, like rice kanji or curd rice, that sort of preparations she could start off with. And initially small fleas and gradually increasing. She should notice if she's adding any new food, then she should notice any changes that the child is vomiting or anything. And whatever they are preparing for themselves can be given to the child as well, is what you should advise. She should not separately cook for the kid because they they excessively dilute the food and all. So you should tell them that whatever you are cooking, that same thing also the child can be given, ma'am.
Anything more anyone wants to add regarding feeding, complementary feeding for a baby? How should be the consistency of a complementary feed? It should not be falling through. It should be semi-solid. It should not be dripping. That is important.
When you take into the spoon, it should form a tongue shape. Okay, it should not be liquid. It should not be dropped.
Then again, we did not tell anything about the food groups. You're telling give home available food. Every day the mother starts giving kanji. Where do you get the micronutrients? Where do you get the protein? So it is important for you to emphasize that calories, proteins and micronutrients are important. So what is the advice you are going to tell her? Which are the food groups that you want the mother to give? How many food groups are there?
5.
3 food groups? 5 food groups. Very good. So what are they? Cereals, pulses, fruits, vegetables, dairy products. So dairy products and meat and this thing would come together. So that's very, very important that you also know the food diversity. Now I would like to know what are the supplements.
With 5 colors.
With 5 colors.
With
5
5 colors.
foods, 5 food groups, 5
colors.
5 times a day for a bigger child. Here you would start with 2 times a day because the baby was already breastfeeding. Otherwise you can, what is the recommended calorie at a 10-month-old child who's breastfeeding? You don't calculate breast milk calories. You need to know how much you want to give. So how much calories would you like to give for a breastfed baby?
100 kilocalories. Ma'am, 100 kilocalories
that
per
should be also calculated into, isn't it?
Yes, sir.
No, that is you are telling about 100 kilocalories holidays agar method for the whole day. I am not asking about that. I am asking for a breastfed mother, what is the amount of calories that the complementary food should be providing? So you have to read it up. 6 to 8 months, it's only 200 calories you want to provide. 8 to 10 months, you want 300 calories. 10 to 12, from 12 months to 23 months, you would like to have 550 calories. So this child would be somewhere between 300 to 400 calories per day is only needed apart from the breast milk. So
the quantum of breast milk breastfeeding also comes down from 6 to 8 times to 4
and
times.
12 to 23 months. Okay. 200, 300 and 550 calories. So that is important. You have to say how much more than the breast milk. Because you have a natural the breast milk will vary from mother to mother, but still it is important for you to know that usually the breast milk will be bridging up the other calories. This you have to make up from extra. What are the complements required or prescribed for a breastfed baby? Any addition, any supplementary things you want to give? Okay, very good. You should have breastfed baby, you should be supplementing vitamin D. Anything else? Iron. Very good. From which month?
From 3rd month.
When is the nadir? Physiological nadir is there, no?
4
Very good. From the 4th month to 1 year of age, how much would you like to give?
3
No. We are supplementing. We are not treating iron deficiency
One-
anemia here.
one
It's only
1
1
mg
mg per kg per day. For a preterm, it is 2 mg per kg per day, provided the child has not received too many blood transfusions in the newborn period. And for preterm, it starts from 1 month. For a term, it starts from 4th month. That is the newest CDC or AAP guidelines that tell you. That is for them. For you, what is it? What does NIPI say for 10-month-old? You said about NIPI.
Yes,
So what do you want to do for this baby? What
uh,
supplement the baby should be on?
Ma'am, usually they say that from 6 months, additionally what they are getting from NIPI is 25 milligrams per day, and of iron should be given, ma'am. The syrup formulation,
Per
20.
Per day, NIPI, 10-month-old baby. How many times a week you want to give?
Ma'am, it's bi-weekly. I'm sorry, ma'am. Bi-weekly, 20 milligrams. And for an older child, it is 45, not per day, ma'am. Bi-weekly.
Bi-weekly. So that's easy to remember. How do you remember it's bi-weekly? For everyone else, it is weekly. So it is bi-weekly because the child is not going to school. So preschool, you are going to give bi-weekly. So that should be easy for you to know. So 20 milligram iron with 45 with your folic acid along with it.
So at this juncture, I would like to bring it all of you. Just now we have celebrated and empowered International Women's Day by calling onto the stage all of you. At the same time, pertaining to our presentation and discussion here, what is the important day today with reference to nutrition? Can anyone? I can give you 1,000 rupees. Those who answer the question. Ten seconds over. This is the March 8th, 2018, the Boshan Abhiyan was introduced. What is Boshan Abhiyan, by the way?
Sir, it was started by our Honorable Prime Minister in the state of Rajasthan, sir. It is now implemented in 315 districts. It was basically to bring together all the existing services that we have. Basically, it was for stunted children, and by 2022, the stunting should reduce to 25%, which is now 38% by the NFHS 4 data. And they want to incorporate height that is taken at all Anganwadis.
The target is 2022.
And they also the existing registers should be eliminated, and a new documentary system should be started where the Anganwadi workers are trained to take height every time the children come there, ma'am.
So, to prevent and reduce stunting in children 0 to 6 years by 6% at the rate of 2 per annum. This is goal number 1. Goal number 2 is prevent and reduce undernutrition in children, again 0 to 6 years, by 6% at the rate of 2% per annum. The Boshan, if you could expand it, as Prime Minister's overarching scheme for holistic nutrition. So, again it envisages at 3 levels. One is the household, next one is the community, third one is the governance. You are the governance. Household, at each house, what they prepare, how is it, where the knowledge is there about the complementary feeding, how to give, what to give, as I told you. And the community, is it acceptable by the community, and varies from different parts and different ethnic groups. And the governance is one which will have to have a monitoring system. That is what you are saying, ICD centers. Okay, right, go ahead.
2 more things. This child, when would you introduce the finger foods?
Ma'am, we will introduce it at normally, ma'am, at 8 months of age.
At 8 months. That is when the child starts sitting up. When the child can sit up and hold on, you make the baby enjoy the food. You should not allow the baby watching the TV feeding. That is what we commonly do. But that is how they become fussy eaters also. So you have to, so don't be bothered about the baby spilling everywhere, the baby making it dirty, but you have to make the baby enjoy the food. So the finger food should be started at 8 months and lumpy foods.
Ma'am, at 10 months.
10 months, very good. So it is important, you should know that from the move, you are giving a soft food initially. Then you are moving to the lumpy foods by, not lumpy foods, by finger foods by 8 months. And then you are going to lumpy foods by the 10 months. All these parameters are important. As you delay introduction, the baby will not accept the new taste.
Timely, that is what timely complementary feeding.
It's a small window period. When you introduce the correct food at the right window period, the baby, first day the baby might not accept. Don't worry. After 2 days again offer it. It again spits it out. Finally there will be a day when the baby will be accepting the food that you have given. So that's the way you have to progress with the baby. Again, when you have come to the present feeding, why bottle fed?
Ma'am, she's unable to give feeding via she's saying that the child is not accepting when she's giving it by any other mode, so the bottle is convenient for her and she's bottle feeding, ma'am. That's the only answer. That's the honest and only answer, ma'am.
Okay, but that's not usually. Usually in hospital, especially we could have just put an NG tube and ensured that the calorie goes in. Bottle feeding was never a solution. What is your comment regarding the protein excess?
Ma'am, she's receiving Protein X powder, ma'am. That's the reason why the protein has exceeded, ma'am. She's giving
why
8.
Is his muscles wasted if he's receiving
ma'am, because
enough protein?
she started 2 days ago, ma'am.
But even before that, she was on milk, right? Even then you have
ma'am, but it was only milk, but it was cow's milk, ma'am. So that is delivering 3 grams per 100 ml of cow's milk, ma'am.
I am sure it must have been prescribed by the treating doctor, maybe a surgeon, right? Okay.
Again, you have to also see whether the cow's milk that is being given is diluted or undiluted.
No, ma'am, she's not diluting it at all. Whole milk is being.
Till what month do you allow a diluted cow's milk?
Ma'am, only till 6 to 7 months. After that, you can.
6 to 7 months? Only till 1 month. Ideally, animal milk should be introduced only after 1 year. But if you are introducing in a dire situation, it is diluted only till 1 month of age. After that, it is undiluted cow's milk. Okay,
so, before we pass on from the complementary feeding, all of you must know the 1000 days concept. So, we have discussed, madam has discussed up to 12 months. 12 to 24 months, how do you expect the child to be fed? It is the child has to feed on himself or herself. The mother should never be forcibly fed. So, you should encourage self-feeding. Most of the mothers might come and complain to you, my child is not eating well. That is, therefore, it is what is to happen, a pleasurable act has become a painful. And most of the home, you can see the war between the mother and the child. It is because when she tries to force feed, the aversion occurs. Okay, so the self-feeding, we should resort to only, as madam said, the finger feeding comes, lumpy feeds comes, then you have to eat the calorie dense food prepared in a solid way. Baby has to eat by himself or herself. So self-feeding. So if you could resort to self-feeding after 12 months to 24 months, you will be successful in the completion of the 1000 days concept, therefore the complementary feeding. Yes.
The child is developmentally normal till surgery was performed.
I think for a 10-month-old baby, for a presentation, just telling developmentally normal wouldn't do.
Yes,
it is very important that you have to spell it out exactly what the baby was doing. Can development be delayed by malnutrition?
Definitely can be delayed, ma'am. Actually, she is claiming, ma'am, if you want, I'll just quickly go through the...
it's okay. You can proceed, but definitely a malnourished child definitely undergoes a developmental delay. So there is no way we can just casually say it's normal.
Ma'am, till 8, the child has received, has attained all milestones till 8 months of age, that the child was sitting with support. Now post surgery, because there is a tube.
No, I only want the milestones at 8 months. What all the baby was doing at 8 months?
Ma'am, the baby was sitting only with support, ma'am. The baby was recognizing parents. That's coming to the social. Fine motors, ma'am. The baby was, she's saying, grasping a rattle and playing with it, ma'am.
8 months, that is enough? Grasping a rattle? At what age would the baby grasp a rattle? What age baby would reach out? I think we won't concentrate on that, but I would say that
at 6 months, but she's saying that's what the baby was doing, that just grasping.
So then your development is not normal. Right? And 8 months should be sitting without support. Long time she should have been playing, transfer of objects should have been attained long back. It's cooing should be there, monosyllables should have come, now it's 9 months. So next time when you try to take development, more detail. Immunization history you have received, child has not received the 9-month immunization. If this was a pre-existing malnourished child admitted in your institute at 8 months of age, what change in immunization would you do? you would give measles vaccination, what would you document? Would you document or would you not document? What is the guideline? You need to document it, and you have to document it as MCV 0. MCV 1 will be after 9 months. You have to take the MCV 1 after 9 months, but it needs to be documented at MCV 0. What is the importance of measles vaccination? For every child with severe acute malnutrition who is admitted in your hospital, we already said that the measles itself can push a child in a borderline malnutrition to severe malnutrition, can aggravate the disease, and if the child gets a measles, it will be very worse. So it is mandated, but this child it's not applicable because the child has come in a surgical emergency, that is different. But otherwise, every malnourished child needs a vaccination at admission. Okay. And what about rotavirus vaccine for this child, if this baby was unimmunized at this point?
Ma'am, as per Rota is still an optional vaccine in a lot of states. However, she's coming from Andhra Pradesh. So there they still are giving rotavirus, but there are no records to prove that she's received a Rota vaccination.
And
however,
what is the normal recommendation?
Ma'am,
if what age in national immunization schedule would you give a rotavirus vaccine?
Ma'am, you can give it till 32 weeks. Beyond that, the risk
in
of...
national immunization schedule, what is the upper age limit for rotavirus vaccination?
1 year.
1 year. Okay, that is for the IAP recommendation. For national schedule, it is 1 year. What are the contraindications? Interception and severe combined immunodeficiency. Is surgical abdominal surgery a contraindication? No, it's only a precaution. It is a precaution, it is not a contraindication. What are the non-GI causes of precautions for rotavirus vaccine? Non-GI indication for rotavirus precaution. Anyone, anything? Any vaccine, only one particular brand has. In fact, spina bifida and bladder extrophy are precautions for rotavirus vaccine. You need to know why should it be a precaution? Nothing to do with the GI. It's only a precaution because spina bifida is associated with latex allergy more, and the Rotarix has a latex applicator. So that also you need to know. Okay.
Ma'am, socio-economic, the child belongs to class 4, upper lower class as per Kuppuswamy scale. They live in a Pakka house. The mother claims that she's giving boiled water to the baby. There are 2 rooms with a total of 4 members residing. There is no separate kitchen. There is no history of any open-air defecation, and the father is a labourer. The mother is illiterate and she is a housewife.
Very good. So mother's literacy is very important.
I haven't, sorry ma'am, I forgot to mention.
It's okay. Mother's literacy is also important, and I would also like to know any food fads, any cultural beliefs, any skipping of foods. That's important.
Okay. Ma'am, they're eating. She was very willing to even introduce non-vegetarian food, but somebody has advised her outside somewhere, so she hasn't done that yet. Okay. No specific food fads as such. Examination. The child was irritated.
At the same time, don't underestimate if she is from a village, because the food fads are not there. The taboo is not there no longer. They tend to eat whatever is available there. And we are going into the flax seeds bio village concept, FBC. So cultivating, harvesting wealth, cultivating health. That is the concept. So village, no, never undermine them. They are always undernourished.
The child is irritable, dull looking, was resenting examination. The child appears emaciated, generalized wasting is observed, normothermic, pallor is present, there is no evidence of any clubbing, cyanosis, lymphadenopathy or edema. The heart rate was 112 per minute, respiratory rate was 32 per minute, and temperature.
Next, fast.
Okay. Anthropometry, sir. If I could just show the growth charts here, just to run through it. The weight for age is less than third standard deviation.
What this about the head circumference in this child? Is it affected?
Less, yes sir, it is affected sir. It is 43.5.
How do you know? How much was the birth at birth? How do you know that?
Sir, we can assume it was 35, sir, because the child was 3.5 kgs at that time, discharged without any complications. There was no history of NICU stay, cried immediately at birth. She's not...
so how much is increased now?
So currently now it is at the height circumference that should equal to a 6-month-old child, sir, 43, sir.
43,
yes, sir.
Can Head circumference decrease with malnutrition?
Definitely, ma'am.
Long-standing malnutrition. So if you are trying to tell me it's an acute malnutrition, no. A little bit long-standing malnutrition can only cause a decrease.
But ma'am, it's not a microcephaly. It's not below 3.
Microcephaly.
Let us not discuss about that here. Okay. Go on.
What is the difference between these two charts that you have shown?
Ma'am, one is a percentile chart and one is the Z-score charting,
ma'am.
ma'am.
That is preferred in malnutrition?
The Z-score is
always the
preferred,
Z-score.
ma'am.
What is the difference between the Z-score and the centile chart? She said less than third centile. So does that naturally mean it is severe malnutrition? Less than the, very good, less than the first centile is severe malnutrition. Because you know that between 2 and 3 it is moderate malnutrition. Less than 3 standard deviation only you take it as severe mal. For a normal child, you telling the centile is okay, but for a malnourished child, always go for the Z scores. Okay.
Who invented this growth chart? Road to health chart.
Yeah, David.
Okay, very good.
The length for age was between 0 to -2 standard deviation. Weight for length was less than 3 standard deviation. Head circumference is falling between -1 to -2 standard deviation. The head to toe exam.
Your impression. Anthropometry impression.
Ma'am, sorry ma'am.
Okay, say.
Ma'am, we come to know that the weight for height is less than -3 standard deviation, which is fitting into the criteria of severe acute malnutrition. Also, the mid-arm circumference is 10 centimeters, ma'am. It was in a slide above, so that also comes into the classification of severe acute malnutrition. Most likely, it looks like
that is in the end. So this, after you have presented the anthropometry, it is important for you to say whether what do you think, it is severe acute or chronic. Here the height is spared, whereas the weight and weight for height is not spared. So you should say that this is an acute malnutrition more than a chronic malnutrition, and you can see that the head circumference is in fact spared. It is not really less than the third centile. So you should define, after you do an anthropometric measurement, it is important to spell out the assessment of the anthropometry. Okay.
The head to toe examination, ma'am, the anterior fontanelle is admitting 1 fingertip. Hair is sparse, thin and lusterless. Old man appearance is seen. There is loss of buccal pad of fat. Pallor is present. The ball tongue is visualized in the oral cavity. No other ulcers.
Wait. Regarding hair, any other comment you would like to know?
Flags.
Where would you look for the flag sign in this particular child who has given you an acute malnutrition for the last 1 month?
Ma'am, the root.
Very good. So it is important that you have to specifically mention whether the root of the tongue is hypopigmented or not. You are not really expecting a flag here, because once he has fallen into the malnutrition, he has not regained it. So not yet time for a flag. But you have to look at the root of the hair to see whether it is hypopigmented or not. Again, oral cavity, it is not only the tongue that you have to say.
Ma'am, the mucus. Ma'am, there is delayed dentition in this child, ma'am. He's still not developed any teeth, ma'am. There are no ulcers, there are no mucosal plaques. The tongue is bald, so ma'am, there are papillary atrophy is seen, ma'am.
Okay, proceed fast.
So Aarti, what does it indicate when there is a loss of buccal fat?
Sir, it's grade 4 marasmus, sir.
Why it should get lost in the last, as far as the grading is concerned?
Sir, because this is the least amount of fat that is there, sir.
2 things you must know. What is the name of the fat? Why it should get lost in the last? It's a
White
quiz question
fat,
for you.
Sir.
Okay. So, கன்னத்துல குழி விழுறது நல்லதா நல்லது இல்லையா? Is it a sign of good health or real health? It's a point to ponder. Okay, right. Go ahead.
No.
Just for on the lighter side.
The chest and abdomen, surgical drainage tube along with the dressing is observed. There is no rachitic or scorbutic rosary, no pectus, no pigeon chest, no Harrison sulcus was seen. The extremities, wasting is noted. Hypo and hypopigmented patches are seen all over the skin, and decreased skin turgor is observed. A baggy pant appearance is seen over the gluteal region. This is a clinical picture.
Again, I would have, when you said about the head to foot examination, definitely I would have liked you to specifically mention the nail changes. whether there is a white nail, whether there is spooning, whether you're finding any ridges. So that's important. So nail specifically you have to say whether it is normal or abnormal, because till now from the history I'm not convinced that this is really a malnutrition happening only after admission. The history tells you that the malnutrition has started from the sixth month of age. Okay.
Right from the start of complementary
feeding where it was faltered. Okay.
Systemic examination, ma'am. S1, S2 was heard. No murmurs were audible.
Okay,
there is
so
no.
those examinations per se is normal. You have not found anything. So what's your final diagnosis?
Ma'am, a 10-month-old child presenting with complaints of vomiting for 1 month and abdominal distension. Seems to be a case of severe acute malnutrition. Marasmus being grade 4. Most likely secondary to an underlying surgical cause, ma'am.
Anyone wants to add anything more to the diagnosis?
With probably iron deficiency, like anemia present with no other micronutrient deficiency.
You have a palmar pallor, you have a bald's tongue. How could you say you have a sparse skin? You have a hyperpigmented dermatosis. How can you say that there is no evidence of vitamin and mineral deficiency? Okay, that is there. Again, you have. It's good you have written that. It is a grade 4. Anything more you want to write? Say. When you say it should be a case of severe acute malnutrition as evidenced by a MUAC less than 11.5 with a weight for age, weight for height less than 3 standard deviations, and secondary lactation failure. This is a case of secondary lactation failure with faulty complementary feeding, evidence of micronutrient deficiency, and aggravated or further worsened by the surgical cause. So that should be your complete diagnosis. Okay, the whole thing, the diagnosis should tell you the story of the child and not just the surgical cause. Okay. I think time up, we wind up.
Yeah, we want to have the audience interaction at the end for 3 minutes. 3 minutes. So, you have mentioned only the child is irritable, isn't it?
Yes, sir.
Any other? Madam Lima Paulin is here, our expert neurologist. Anything else when you look into the neurological aspect of this child, you would like to ask?
Sir, if
what contributes? What are the substances which are responsible for this?
Sir, if this was an old...
Is there any neurotransmitter involved here? What are the coenzymes?
Sir, if this was an older child, we could also probably ask about the mental status and the scholastic performance. But since it's a 9-month-old child, you can only comment upon irritability, apathy, and peevish-looking appearance of the child, sir.
Is that only thing?
Will iron deficiency affect your intellectual function? Why? What is iron needed for you in the brain?
Ma'am, it basically it's a part of your hemoglobin, ma'am. So it there is
only
oxygen.
The anything more in the iron?
Ma'am, it brain development
and myelination also.
What is the role of EFA, essential fatty acids?
Sir, EFA
that is the nutrition star. You are like looking like a star. So I would focus on essential fatty acid as a nutrition star.
Sir, EFA was also called vitamin F also, sir, and it also helps in the linolenic acid and linoleic acid are the essential essential fatty acids, sir. You need them for the myelination process also, sir, in CNS development.
Okay. When you have a
hormones, coenzymes, and so on, that is also.
When you have a child with severe malnutrition, why is it that you start the feeding so cautiously? You're starting with F75, which gives you a protein of only 0.9 gram or 1 gram and only 75 calories. So why is it you do that? Refeeding. So what happens in a refeeding syndrome? Why does it happen?
Ma'am, basically in a severe acute malnutrition condition, the cortisol levels are high. So when and your insulin levels are low. So suddenly if you pump a lot of glucose into the child, your insulin levels will become high and they will cause. And for the glucose to metabolize, you will need, there will be pushing in of potassium and phosphorus into the cells to metabolize all what you are giving, which will lead to hypophosphatemia, hypokalemia, hypocalcemia, hypomagnesemia, which will have disastrous results.
That's not only just the insulin, it's mainly the calorie excess is going to suddenly restore your sodium potassium ATPase, which is going to cause the sodium to come outside, making the edema worsen, and your potassium along with glucose, magnesium and phosphorus going in, causing the refeeding syndrome that is happening.
If at all you would like to have a SAM, which is the best form of SAM? Marasmus, marasmic kwashiorkor or kwashiorkor?
Marasmus.
Which is dangerous?
Marasmus.
Marasmic kwashiorkor. Marasmic kwashiorkor.
How do you diagnose iron deficiency? I'm not asking iron deficiency anemia. I'm asking iron deficiency. How would you diagnose? How would you diagnose iron deficiency? Because deficiency is enough for your neurological abnormality to be set in. History diagnosis, huh? No protoporphyrin. How would you? Very good. You could look for, but you have to always combine serum ferritin with CRP. Otherwise, you could look for the hemoglobin reticount. That is what is the diagnostic of iron deficiency. It's important that you pick up iron deficiency before a child goes in for iron deficiency anemia. Here the pallor, what all could be the reasons that a child with malnutrition has pallor?
Ma'am, she's predominantly giving cow's milk, ma'am.
Tell me the causes of malnutrition pallor.
Ma'am, the child could be having edema that will cause pallor itself, ma'am. She's not feeding properly, she's only giving cow's milk, that will cause pallor. Since this is a surgical case, ma'am, the child may be losing blood, like bleeding PR or blood in vomitus or something, ma'am. That could also lead to pallor in this child, ma'am.
In fact, you should read it up. There's a lot of things: iron deficiency, folic acid, B12 deficiency, protein deficiency, concurrent worm infestations. Everything will contribute to a pallor in it.
Why iron should not be given in the initial phase?
Free radical injury.
Okay, somebody may ask you what is RUTF? What is it?
Sir, it's ready to eat, ready to use therapeutic food.
What are the compositions?
Rice, wheat.
No rice.
What is the concept of RUTF?
Ma'am, that base F100, the 20 grams is equal to 100 ml, ma'am.
So it should be a calorie rich. What is the basic concept of
ma'am,
RUTF?
it will provide you with 15 grams of protein and 500 kilocalories, ma'am. It's a very energy dense food, ma'am.
Anything that gives you 15 gram of protein and 500 calorie becomes an RUTF? No.
Easy.
So?
Ma'am, it's easy to prepare and easy digestibility.
Anything that is easy to prepare becomes an RUTF. The main thing is it should be calorie rich, protein rich. It should not contain water. That is the main thing. It can be easily stored and directly fed to the child.
Ma'am, because water will cause infections. That's why they don't give.
That's the main reason why the RUTF was introduced.
So reporting of the SAM also is important. When it comes to the reporting, you need to know the ICD classification. How do you classify which comes under ICD classification? It is ICD-10 starting from E40, 42, 43, 46. Okay, E42 is marasmus. So ICD-10, 42, that should be the notification. Okay. I think there are no more questions. Hope you all to some extent apprised about. I think nutrition can't be finished with a time set. It should always go overshoot the time. But with keeping the mind in restrictions, I think we'll wind up. Thank you very much for the opportunity given.
I request the delegates to stay. The next important session is degenerative disorder. The lunch will be after 2 p.m. Please stay back.
Examination and 30 minutes, 20 minutes for examination. Am I correct or not? Sure. Yeah.
Thank you, sir and ma'am, for your mind-boggling session.
Yeah.